Welcome to the workshop, Graft-versus-Host Disease, Gastrointestinal Tract, and Liver. My name is Anna, and I will be your moderator for this workshop. I'd like to thank Incyte and Ironwood Pharmaceuticals, whose support helped make this workshop possible. It's my pleasure to introduce today's speaker, Dr. Hannah Choe. Dr. Choe is an assistant professor and hematologist at The Ohio State University Comprehensive Cancer Center, where she specializes in blood and marrow stem cell transplantation and treating patients with myeloid diseases such as acute myeloid leukemia, or AML, and myeloproliferative diseases. She is also the director of the Ohio State University Graft-versus-Host Disease, or GVHD, program. Her research focuses on new approaches to prevent and better treat GVHD. Please join me in welcoming Dr. Choe.
Thank you, Anna, and good afternoon. Sherry, do you mind advancing the next slide? Thank you. My name is Hannah Choe. I am a transplant hematologist oncologist at OSU, as Anna mentioned. For the next 40 minutes or so, I'll be reviewing graft-versus-host disease of the GI tract and liver. There's so much we could discuss, but we will keep it to the following learning objectives. Next slide. We will be going over the incidence or rate of occurrence of acute and chronic graft-versus-host disease of the GI tract and liver. We'll cover the risk factors and treatment options as well. Next slide. We'll first review acute and chronic GVHD of the GI tract, signs and symptoms, and how this might be diagnosed. Then we'll do the same for acute and chronic liver graft-versus-host disease. And lastly, we'll review treatment options, which are the same regardless of which organs are involved, but we will cover the responsiveness of each of these drugs that I'm going to be discussing forthcoming. Next slide. So there are a few things that are more important than food and water, and the GI tract helps us manage both. From our mouths to esophagus to stomach to small intestine to colon and through the anus or rectum, the GI tract is responsible for digesting food and helping us derive our nutrients from our food and water. It is also our waste management system. Because the cells on the inner lining of our GI tract are constantly growing and sloughing off with very high cell turnover, our GI tract is more sensitive to chemotherapy and also to radiation, similar to how our patients will lose hair or have skin changes as side effects from the chemotherapy. But in particular, we know that many of the chemotherapies that we use for stem cell transplantation, conditioning chemotherapy prior to stem cell infusion, will cause GI side effects. So the risk of developing GVHD of the GI tract starts with the chemotherapy that our patients are receiving even before they receive their stem cell infusion. Further risk of GI GVHD, or really any type of GVHD, depends on how many donor cells a patient receives and how well matched they are to the patient. The better the match, the less likely a patient is to have graft-versus-host disease. But this risk can be offset by the GVHD prophylaxis medications or prevention medications that are used with that chemotherapy and then continued on for maintenance after stem cell transplant to prevent graft-versus-host disease. Next slide. The GI tract is also importantly a site of immune system activation. So at a continuous level, our immune system is at the ready in our GI tracts in case the bacteria that are in our gut try to cross over. So with chemotherapy that then goes in and disrupts the GI tract, causing damage and injury there, the immune system is then further activated, which is not only there to just fend off bacterial infections, but then also there to repair the GI tract. So this immune cell activation in our GI tract then stimulates the donor cells that we've just infused into the patient and leads to more inflammation and sets off graft-versus-host disease. And so the GI tract is really a primary site of activation for GVHD. You can then see how the GI tract easily becomes the central focus and a commonplace symptom of one of the first symptoms of GVHD. So roughly 70% of patients who have grade 2 to 4 acute GVHD in fact involve the GI tract. The lower GI tract is also harder to treat than skin or upper GI acute GVHD, and we know that when the lower GI tract is involved, patients are at higher risk of mortality. So we know then that treatments also don't work as well, and 73% of patients with severe acute GI GVHD can stop responding to the frontline treatment of steroids or don't show a response to steroids within 2 weeks. So we do take it much more seriously when a patient does show initial signs of potential GVHD, and are always then questioning our patients about any diarrhea or new GI symptoms. So having GI GVHD is very significant, and so we'll often make what's previously an uncomfortable topic to ask about diarrhea and stool output something very commonplace within the clinic. Next slide. To assess for acute GI GVHD, we ask about your appetite, if you're getting full earlier, if you're having heartburn, feeling nauseous or vomiting, or perhaps if you're losing weight, because any of these symptoms could be signs of GI GVHD. We also ask about abdominal pain and any signs of diarrhea. And we also care specifically a lot about the diarrhea because it signals that patients are not absorbing water and nutrients, and so we have to worry about dehydration and malnutrition. So we really have to stay ahead of this and stay on top of it, and why we always ask patients to call immediately at initial signs, even if it turns out to not be graft-versus-host disease ultimately. Next slide. To gauge how severe the GVHD then is, we do what is called staging. We assign the stage of severity by if there is persistent nausea or vomiting and how much diarrhea or how many stools a patient is having every day. More diarrhea signals then more advanced disease. Next slide. We combine the staging calculation with that of the skin and the liver, and we determine an overall grade of acute GI GVHD. But for chronic, it's a bit different. So next slide. Chronic GI GVHD can more commonly involve the mouth, esophagus, and GI tract, and also the GI tract, whereas acute GVHD rarely involves the mouth or the esophagus, although patients can have mucositis from their chemotherapy that seems to blend into it. With chronic GI GVHD, patients will complain of oral dryness, mouth ulcers, blistering, or sensitivities to food. In particular, I have patients that complain often about tomatoes or tomato sauces or Italian foods. And then so also that goes along with this, essentially if foods are more acidic. They might also complain about difficulty swallowing and feeling like food is getting stuck because literally there is narrowing of the esophagus that blocks the food transit down to the stomach. Other chronic GI GVHD symptoms mirror that of acute GVHD when it involves the stomach and lower GI tract with the nausea, vomiting, diarrhea, and potential weight loss. Next slide. These symptoms vary in severity, and we use the symptoms to grade the severities. So since we're talking about mouth, esophagus, and other, it's a little bit more broad than with acute GVHD. So for chronic GVHD, in the case of mouth symptoms, we interpret severity based off of how much the GVHD limits the patient's ability to eat. So that can be very subjective initially, but it's really important to dig into the details with your provider and make sure that they're aware of how much change has happened for you if you're eating less, or if you're not able to keep food down, or if you feel like it's just too painful for you to eat or swallow, or if your mouth is again too dry for you to be able to produce enough saliva to be able to swallow, for example. For the GI tract, we mark the symptoms, including if there is an esophageal stricture or narrowing of the esophagus, and we consider more severe GVHD to be that leads to more weight loss or ability to get enough nutrition, or even requiring a procedure for you to undergo, or if it's affecting your daily activities. So not as objective of a scale than we use for acute GVHD. Next slide. To fully evaluate for all these GI symptoms for acute or chronic GVHD, multiple tests are ordered. We might include stool studies to rule out infection, perform an endoscopy of the upper and or lower GI tract. So an upper endoscopy is also called an EGD. And a colonoscopy is obviously through the rectum, but could also be a flexible sigmoidoscopy, which is a shorter view of the more of the GI tissue closer to your rectum. Additional blood work may be sent for blood counts, chemistry panels to check your kidney and liver function as well, looking for other signs of other organ involvement. GVHD biomarkers can be sent, and blood markers of nutrition like your vitamin levels or your mineral levels to signal whether you've had more malabsorption or are having other signs of malnutrition. Sometimes imaging studies like with a CT scan or MRI are also ordered to rule out other issues or to also see if there's actually been improvements or worsening of your GVHD. Next slide. These are example images of an upper endoscopy or EGD, as I mentioned, from a patient with liver GVHD. You can see the images are taken with the forceps or cryotherapy tools that the GI doctor uses to take biopsies or to treat certain areas. In this case, we're used to treat to stop bleeding. Next slide. GVHD is a clinical diagnosis. So that means we diagnose based only on symptoms. But it does not mean we do not still try to hone or get more specifics about the diagnosis or potentially to confirm it when it's possible to get tissue biopsy. So biopsies are not always required, and patients may be started on treatment based solely off of how much diarrhea or other symptoms they're having, but biopsies can be very helpful. Besides the amount of diarrhea someone is having, biopsies can tell us how severe the damage is to the GI tract. It also allows us to do particular tests to rule out that an infection is also there or instead there and there's actually no GVHD. Biopsies may also need to be repeated after some time if symptoms do change, particularly if symptoms get worse despite treatment, because you then might need to rule out, well, there wasn't an infection there before, but there could be an infection now. And it also can help us assess whether a patient is responding or not responding, because there could also be other causes of diarrhea. Could be from new medications, or and so a patient could be having improved GVHD, but their diarrhea is worsening, and it might not. And so the biopsy helps us to specify that. Next slide. The second organ system we're going to talk about today is the liver. The liver has many different functions. So listed here, it's not all encompassing. The liver filters blood and removes toxins, makes bile that helps us digest food, makes proteins that keep us from bleeding, it helps us balance fluid, regulates our bodies in general. And importantly, this involves metabolizing and processing medications too. So any damage from any particular disease, but particularly from GVHD in this case, can lead to scar tissue formation or scarring within the liver, which eventually leads to cirrhosis. When that happens, the liver is functioning less well, and then these important responsibilities start to falter, and that's when patients might start to show more symptoms. Next slide. So the signs or symptoms, unlike with acute liver GVHD, oftentimes our initial suspicion for a patient to have liver GVHD is when there might not be any symptoms at all, and based off of just lab values that we're routinely checking. But rarely a patient might also be jaundiced. So we are regularly checking at follow-up visits soon after transplantation your chemistry panel, which should include your alkaline phosphatase, your AST, ALT, and your bilirubin numbers, and we'll talk a little bit more about those going forward. Next slide. This is the same for chronic GVHD, where it's often the labs that tip us off initially that something is off. Next slide. So signs and symptoms of more serious or severe GVHD of the liver are not specific to graft-versus-host disease, but these include jaundice, which is yellowing of the skin and eyes, swelling, and other signs of fluid overload, particularly in the abdomen and the legs, and any signs of increased bleeding symptoms, particularly from the nose or from the rectum, or any increased bruising. If advanced, patients can have confusion and enter dark urine. Next slide. Because the clinical signs and symptoms can vary between patients and do not accurately reflect the severity of the disease, our scoring for acute and chronic GVHD is based off of the lab values. So here we show the scale that's used for chronic graft-versus-host disease that uses the total bilirubin, the ALT, and alkaline phosphatase numbers. These are all results on a comprehensive metabolic panel, or CMP, that is routinely ordered by your provider. Next slide. The rate of occurrence or incidence of liver GVHD is more common in chronic than acute. While these ranges, as you're seeing them here, 6 to 15% for acute and 5 to 31% for chronic, do overlap, most reports would say that rates of acute liver GVHD are near the lower end, towards the 6%, and whereas chronic liver GVHD, most reports would say more towards the higher end, towards the 30%. We'll go into that a little bit more. Next slide. Over time, looking at all the cases of chronic GVHD and breaking it down into the main organ systems, roughly 50% of patients over time from 1995 to 99, 2000 to 2003, 2004 to 2007 have ranged around 50% that involve the liver. For GI and weight loss, also relatively stable, 39 to 41 to 34%, it's about 1 in 3. And then you can see that for mouth above as well. So while other organ systems incidence have changed over time, the liver and GI tract have stayed pretty stable. And things like the skin here, though the rate has increased, it's probably not that the rate of skin GVHD has increased so much as that we are diagnosing it more readily and making that number seem higher. But generally, the organ system breakdown is pretty stable over time, and about roughly 1/3 have, for chronic GVHD symptoms, or have GI involvement, and 1/2 of patients have liver involvement. Next slide. Other facts about liver GVHD in general is that it appears about 2 months to 2 years after transplant. So there's a wide range that it can first show signs or symptoms, which is why it's important to continue to have routine follow-up with your provider, even well after you've completed your stem cell transplantation, and even after you've been weaned off of immunosuppression. And this liver GVHD can affect up to, and this is probably a high number, but it can affect up to 75% of all patients by some reports. It typically presents with a cholestatic pattern where there is a decreased bile flow through the liver. So cholestasis basically means that there is decreased flow through your liver, and so that backup of flow causes the symptoms of the bilirubin accumulating, and why you develop the symptoms of jaundice or yellowing of the skin and eyes. But it can also be hepatitic, or show up as like a hepatitis, which is inflammation of the liver, where it particularly causes increases in your lab work for your liver transaminases, like your AST or ALT numbers, again, routinely seen on your metabolic panel. And so you might have an increase in those numbers, AST and ALT, but not have an increase in bilirubin. So imaging such as with ultrasound, CT, or MRI are not diagnostic, but they can help you identify if there needs to be a closer examination, and particularly with a liver biopsy. Next slide. So AST and ALT elevations, also alkaline phosphatase, hyperbilirubinemia, which is where your bilirubin numbers are higher, and even seeing other changes, even if you do pursue a liver biopsy and that show maybe even scar tissue already there, does not always mean that it's GVHD. It could be, here included, a list of different other complications even before or after stem cell transplantation that have carried over, and it can be very broad. So there are common mimics to graft-versus-host disease, very commonly drug-induced liver injury, which, as it sounds, could be a medication that you received that, for whatever reason, had side effects where it caused damage to your liver. It could have been an infection. So checking, we do check hepatitis B and C prior to stem cell transplantation, but should be routinely checked to make sure that that is ruled out. But it could also be a CMV, or a cytomegalovirus, which is something that we commonly check and routinely make sure it's not reactivating after stem cell transplantation, causing liver issues, or adenovirus, the same thing, or even a fungal infection. And so these other causes that can be mimicked can be difficult to distinguish even with a biopsy. So it has to be a very educated decision that this is most likely chronic GVHD or acute GVHD. There are other causes listed here of liver abnormalities, such as veno-occlusive disease or sinusoidal obstructive syndrome. Iron overload can do this, so if you've received many transfusions over time, having elevated levels of iron can also damage your liver. If you had a very severe infection and you were septic, then you can actually have a similar cholestatic picture just from being septic. And then also steatohepatitis and steatosis, or if there's underlying malignancy within your liver as well. Steatohepatitis and steatosis refer to the deposition of fat in your liver that can cause more inflammation, which is increasingly a problem. So also to keep in mind, though, that it could be liver GVHD and one of these other things. So just because you have one of these diagnoses, such as steatosis, does not mean you can't also have liver GVHD. So this further complicates the diagnosis of liver GVHD, meaning getting all the information, lab values, potentially tissue biopsy and imaging help us narrow and make an educated decision about how to proceed. Next slide. To figure out, as I mentioned, your healthcare provider would order these studies, and in addition, oftentimes a referral to a liver specialist, also called a hepatologist, can be helpful to make sure that we're ruling out other potential liver-specific complications or liver-specific causes that we might not be considering. So it becomes a multidisciplinary care team quickly when there's liver GVHD involved. Next slide. As I mentioned, liver biopsy can be very important, and I do want to take a minute to discuss the importance of biopsy and information that I think is important for the patient to understand. So it might be surprising, despite me talking about how difficult it is to diagnose liver GVHD, that it's more an exception to a rule than a rule that we actually obtain a liver biopsy. Despite its utility and its helpfulness to narrow or confirm the diagnosis, oftentimes getting a liver biopsy is deferred or delayed or not done just due to the perception that there's an increased risk of bleeding or complications that make it not worth the benefit of getting that biopsy. But an NIH cross-sectional study that they published last year looked at 315 patients that were diagnosed clinically with liver GVHD just based off of lab values alone. And these lab value cutoffs that they used were when your ALT or bilirubin were 3 times normal and had no other explanation. This resulted in half of the patients with this clinical liver GVHD diagnosis to be about 150 to 160 patients. But only 32 of those 150 to 160 patients actually had a liver biopsy or liver tissue from an autopsy. And so from that information is that only 60% of those samples were actually liver GVHD. So unfortunately, there's not a lot of tissues to be able to look at, but even from the ones that they did have, when they were diagnosed with liver GVHD just based off of labs, only 60% of them actually were liver GVHD. So 41% of these samples had no liver GVHD. So this can then have major implications. Patients on treatment for with immunosuppressive therapies when they might not actually need it, or they might have an underlying condition that is not GVHD that we're not recognizing. So there's, of course, the caveat that the biopsy is not also 100% diagnostic. So just getting a biopsy doesn't mean that we're going to have all the information, that it will definitely guarantee that we do know or do not know. So because we don't have specific features that definitely tell us. So everything has to be used in, all this information has to be used in a very educated manner with your clinical team to piece together to say that this is much more likely to be GVHD and should proceed with treatment versus not. But you can see that it's important to always take a closer look. The next slide. The timing of biopsy is also very important. So as I just mentioned, the biopsy can be very helpful, but if you do it too soon, this can actually result in a false negative. So, and if the patients have been on treatment and then we do the biopsy, then the biopsy might be negative because the treatment has actually already started to help too much. So you have to be judicious about when to ask for the biopsy in general. So this slide again shows additional data basically showing that 50% of biopsy results led to a change in treatment for this case series of patients who had undergone liver biopsies. And if you look at across the published studies that I was able to find, biopsies actually led to a change in treatment for up to 95% of cases in one report. So roughly half of patients, up to most patients, actually had a change in treatment because of what was found on the biopsy. Next slide. What is involved in a liver biopsy, where is it done, and by whom? Typically, it's done through an interventional radiologist team. This can be done either transjugularly through your jugular vein in your neck, or can be done percutaneously, which is through the skin over your liver. It is an outpatient procedure. It does not take very long. Obviously, you need some under moderate sedation, not general anesthesia, but moderate sedation to do the procedure, depending on if they're going transjugular or percutaneous or through the neck versus through the skin. And it's roughly similar to having your tunneled line placed. Very similar procedure, very same team that would be doing it. The pain is obviously ranges for the person, but most patients come out of it similar to having the discomfort you would have, again, to a tunneled line placement, and the recovery time similar, just a few days. Next slide. In a study to try to assess the safety of doing transjugular or percutaneous liver biopsy, there were no adverse events in the majority of patients, in 92%, and of the patients that did, pain was the most common. You can have very regularly a small hematoma or blood collection at where they enter the needle at the neck, and very, very rarely, 0.0015%, was the bleeding so significant from actually doing the procedure that a patient would need a transfusion. So in general, very well tolerated, low risk, but obviously not without any risk. And when you look at other concerns such as whether a patient had a significant hematoma or a pneumothorax, which is where they actually puncture the lung and develop and have sort of a lung deflation issue, that's less than 3% of patients. Next slide. So now that you have a diagnosis after all this, whether it's acute GI GVHD, chronic GI GVHD, acute liver or chronic liver GVHD, what is the treatment? So I put clinical trial here first because clinical trial for me is always the gold standard, because the first line of treatment is steroids. And I don't think I have to elaborate on the side effects and toxicity of steroids. While they can be a very effective treatment at suppressing the immune system and dampening inflammation very quickly, they also very quickly can cause side effects such as high blood sugars, high blood pressure, fatigue, muscle loss, bone density decrease, et cetera, et cetera. So we're constantly, as academicians within the GVHD, trying to find something that's better than steroids, that works just as well, just as quickly. So I always encourage a consideration of what a clinical trial, if one is open near you, for your type of graft-versus-host disease. And if steroids don't work or stop working, then we'll talk about these other these next two agents, ruxolitinib and belumosudil. I do feel like I should say that there is another FDA-approved agent, ibrutinib, which I am not going to be discussing because it is not used commonly in practice as a go-to because of side effects. And then if steroids don't work, then also consideration of clinical trial. I think at any treatment change opportunity, a clinical trial, if available, should be considered. Next slide. So when we look at patients that have acute graft-versus-host disease and we want to get an idea of how well do steroids then work, we have a very well done review that was published in 2015 where we looked at patients who had different stages of GVHD, acute GVHD, which involves the skin, lower or upper GI tract, and the liver. When you break up the different types or categories of organ involvement that patients have, when you have GI involvement, particularly the lower GI tract, which is in the box in the bottom four here, bottom 4 rows, there is a decrease in the response rate 4 weeks later. So 4 weeks later is just an arbitrary marker at this point, but we know that patients will not respond as well if there is lower GI involvement. Next slide. If there is more severe lower GI involvement where it's more advanced with more diarrhea, you can see that those numbers that had been in the 60s, 70s are now the 50s, and been down to 35. And then the most difficult to treat, again, least responsive organs are when you start to involve the liver and even the highest presentations or most advanced severe presentations of lower GI tract involvement. So when you have GI tract involvement and or liver involvement of acute graft-versus-host disease, it's a signal to your provider and your care team that while of course we can give you frontline steroids, you're less likely to respond. And so consideration of next line agents or a clinical trial should be heavily weighted. And the response rates when you start to develop, when you look at liver involvement, again, drop from where you were in the 50s, 60s before, now down into the 30s, 40s. Next slide. So the first medication that I wanted to look at for acute graft-versus-host disease, aside from steroids, so second line after steroids, so the next line agent after steroids, most commonly is ruxolitinib, which is FDA approved. Ruxolitinib is a JAK inhibitor that dampens inflammation by blocking the JAK pathway or JAK-STAT pathway. And when we're specifically looking at lower GI responsiveness, there's no specific numbers that we have because the study was not designed to have a direct comparison, but they did share data where you can get an idea of how bad the staging was before the patient received ruxolitinib, and then 4 weeks later for lower GI tract involvement, and then the same on the right for patients who received on that trial best available therapy. And there were a number of different therapies besides ruxolitinib that were studied. So if a patient had, you can see the patients in the first bar versus the third bar are where patients started initially with treatment, and then you look at the second bar and the fourth bar, you see that the staging might be, if it's lighter colored, less severe with the ruxolitinib than with the best available therapy. But so it seems like the lighter colors reflect that there's less severe graft-versus-host disease and had lower stages after 4 weeks with treatment with ruxolitinib. Next slide. For the liver, this is roughly the same, but harder to tell because the numbers were fewer, but roughly similar between the liver and the best available therapy, maybe slightly better with ruxolitinib. Again, no firm conclusions can be drawn from this because the study was not powered specifically to look at this, but just important information to know when we're trying to sort of say how do we personalize the decision on how to treat a patient with GI tract or liver disease from GVHD. Next slide. When we look at chronic GVHD and see specifically how the mouth, esophagus, upper GI tract, lower GI tract, and liver respond to ruxolitinib, the response rates are high with ruxolitinib, which is the second and third columns, versus best available therapy, which is the fourth and fifth columns on the right here. So you see a baseline involvement and then the organ response. So for the mouth, patients had baseline around 58 to 60%, and then with ruxolitinib, about a 50% response versus 25% with best available therapy. So significant difference with improved responsiveness with mouth. The esophagus, about 10% were involved at baseline, and then there was about 50% response with ruxolitinib versus 30 versus best available therapy for best available therapy. Upper GI tract, 12% at baseline, and then 40% responding in actually both best available therapy and ruxolitinib. For the lower GI tract, about 6 to 10% involvement, and then a 53% response rate with ruxolitinib and about 30% with best available therapy. And liver, similar responses for ruxolitinib and the best available therapy. The next treatment that I wanted to review was, next slide, belumosudil for chronic GVHD. There is no other FDA-approved agent for acute graft-versus-host disease besides ruxolitinib. So that's, again, where I would consider if a patient is not responding to ruxolitinib, where a clinical trial should be considered. But for chronic GVHD, if you have failed 2 prior therapies, then you can consider belumosudil, which is FDA-approved as well, and that study is called the ROCKSTAR study. The response rates here are shown by organ system for belumosudil. There were higher response rates in the lower and GI. There were high response rates within the lower GI and upper GI, and also the esophagus, and a lower response rate in the liver. But this is not compared to anything else. This is just the response rate. This is just comparing it to itself. You see higher response rates in the liver than you, or in the GI tract than you do in the liver here. But actually, still notable response rates in general. Compared to what you would consider for what is not FDA approved and available, which after steroids again and after ruxolitinib, we have no other options as of yet. Okay, next slide. So in summary, the GI tract involvement in acute GVHD is common. About 70% of patients with grade 2 or higher GVHD have GI tract involvement. Liver involvement in acute GVHD is significantly less common, but it is very common in chronic GVHD. That might be, again, because we are diagnosing it based only off of lab values and not commonplace getting liver biopsies. So it is worth a conversation with your provider to discuss whether or not any of your lab abnormalities are due to medications or potentially GVHD. GI tract or liver involvement does increase the risk of mortality in acute GVHD. Interestingly, it does not in chronic GVHD. Chronic GVHD is, thought to be obviously more chronically treated and more of a slow persistence or slow progression. Biopsy is helpful in liver GVHD, in acute or chronic GVHD, and to confirm the diagnosis, rule out other causes, monitor for progression even. And the treatments that we've reviewed include steroids, which the responsiveness can be lower the more advanced your disease is, as for any other treatment, as well as for ruxolitinib and belumosudil. But I do still, again, highly recommend that you consider clinical trials for treatment along at any stage of or any juncture for your GVHD management. And that concludes the presentation that I had prepared. I'll take any questions at this point. Thank you.
Thank you, Dr. Choe, for this excellent presentation. We will now begin the question and answer session. If you have a question for Dr. Choe, please use the chat box on the left side of the screen to submit your question. We will answer as many questions as possible. I see that we have a number in the chat already. And our first question is this: I am 2 years from my bone marrow transplant. I just started having GI issues, and I'm seeing a GI specialist, not a GVHD specialist. They're conducting many of the tests you mentioned. Do I need to see a GVHD specialist?
Yeah, so I would highly encourage for you to follow up with your transplant provider, who obviously will have a high suspicion for graft-versus-host disease as well. So if you have not seen your transplant provider, then I would schedule with them, because the GI, depending on the GI specialist history or experience with graft-versus-host disease, they may not be considering it, and they may then not be looking for the other markers that we would consider important. I'm sure they're probably doing a very good job of trying to support your symptoms that you need to consider GVHD, and if GVHD is in fact the trigger for all of these things, then the treatment would not be through your GI specialist, it would be through your transplant provider or transplant specialist. So yes, I would encourage you to follow up with your transplant physician.
Okay, thank you. The next question is, my allogenic stem cell transplant was in 2018. The oral lesions have improved, but my intestinal cramping and increased peristalsis persists. I cut back on fibrous foods and notice I do better with fatty foods, meat, and exercise improves symptoms. What causes this? I had colitis when I was taking the conditioning treatment. Could this be part of it?
Yeah, so that's really tricky because the symptoms can be very nonspecific, and there's also so many different other GI conditions that can be playing a part, or that could be this instead of GVHD. So without seeing your tissue biopsy or knowing, so for example, inflammatory markers, for example, I don't know how much of it could be GVHD versus not. You know, you have to think about other GI conditions such as pancreatic enzyme production, or irritable bowel syndrome, or I'm assuming you don't have inflammatory bowel disease, but making sure that all of these things are being checked appropriately, because it might not just be your GI tract. If it's digestion, as I mentioned, it could be liver involvement too. So, but usually they see that based off of liver enzymes, but these things should all be considered. So it's hard for me to say without obviously seeing you myself, but you can have responses in one organ, like your mouth, but not have improvement in another. And that would not be uncommon for GVHD. So, so it may be that whatever treatment you're on for your graft-versus-host disease has worked to a certain level. And if this is in fact your graft-versus-host disease that's continuing to cause you these symptoms, you may be in a position to consider whether or not another line of therapy would be more appropriate. But without knowing, you know, more details and obviously specifics about your situation, it's hard to say, but it definitely it would, I would consider looking a little bit further, and then also considering if this is in fact GVHD, whether another treatment would be better for you.
Okay, thank you. The third question is, why do I have random flare-ups in my gut that last about a week, causing pain, indigestion, nausea, and fatigue? I have become sensitive to certain foods such as wheat, oats, and shellfish, to name a few. These foods trigger a reaction in my mouth and often spur a sour or gurgling gut. Is it still safe to eat some of these foods?
Yeah, so as I mentioned, so it's not uncommon for patients to have certain food sensitivities with graft-versus-host disease. So this could be your graft-versus-host disease that's triggered by certain foods that you're eating, or the sensitivities that you're having from graft-versus-host disease are then triggering these symptoms. So I can't, you know, advise whether it's safe or not to be able to eat these things without knowing obviously the details. But I would recommend, you know, deferring, you know, seeing your GI specialist, evaluating whether you need to have repeat scopes done, and then making sure we're identifying that other organ systems besides the GI tract to look for other signs or symptoms of progression of GVHD are there or not, to help make an educated decision. So I can't speak specifically to your specific needs, but it's not uncommon to have food sensitivities, and the persistence of those sensitivities might signal, if in fact due to GVHD, that your GVHD is not well controlled. So I would follow up with your provider about that.
Okay, thank you. And the next question is, how do I best support my wife who constantly feels nausea due to GVHD?
Well, thank you, first of all, for asking on behalf of your wife, because caregivers are so important with managing particularly chronic GVHD or severe chronic GVHD or any GI GVHD, really. But so nausea, it depends on what the trigger for the nausea is. There are many different types of nausea medications, so it would, I think that it's important to understand whether what is triggering the nausea and if it can be managed by medications alone, or if it's GVHD that's not controlled, does she need treatment for the GVHD to help with the nausea? So for nausea in general, a lot of times when we're thinking of upper GI GVHD, we will go to topical, sort of what we call topical, but non-absorbable steroids. So something like budesonide is commonplace. Obviously, anti-nausea medications are commonplace. And then if the endoscopy or EGG does show that the GVHD is not responding, then different GVHD therapies may be considered. I'm trying to think if there's anything that I wanted to touch base about. Oftentimes we'll use beclomethasone in addition to the budesonide. This might involve using a compound pharmacy to obtain these medications. You might also consider whether or not other medications are also contributing to her symptoms as well. So again, GI GVHD being pretty not specific, it could always be a medication that's causing the nausea or something else that's causing the nausea rather than the GVHD as well. So it does, so in that case, an endoscopy could be helpful. So I would follow up with your provider to make sure all these things have been considered and done. Yeah.
Okay, great. The next question is about a 65-year-old male, 10 months post-transplant for MDS. He is having ECP treatment for skin GVHD. So far, no GI GVHD. Is there any chance of getting it from this point forward?
Unfortunately, yes. Obviously, I'm glad that he's on treatment for his GVHD, which should hopefully prevent further progression. But patients can stop responding to treatment, and that's one of the limitations, and one of the things that we're trying to improve is the duration of response, or how long a patient will respond to treatment, because when a treatment does stop working, then we have to consider the next line, or consider what else might be a way to treat their graft-versus-host disease. It's somewhat rare to have what's called a complete response to any of these therapies, which we didn't delve into in the treatment section. But while we might have a high number of patients respond, rarely do we actually get patients to respond completely, where their GVHD goes away completely. And then when we do wean patients and they do come off of therapies, there's always, unfortunately, the chance of that graft-versus-host disease coming back. And when the graft-versus-host disease comes back, it could come back in different organs. So I can't say absolutely that he or she will never develop GI tract GVHD, but it sounds like obviously he or she is receiving active therapy for it. So hopefully it should prevent it as possible. And it's obviously being monitored then for those symptoms. So, but yes, I think you should always be vigilant for if this person develops new symptoms that are GI tract, or if there's liver abnormalities that, given his history of GVHD of the skin, that that could be GI tract or liver GVHD, but would still need its own workup.
Okay, thank you. Do you consider chronic GI GVHD as a process that can, quote unquote, burn out, or needs to be managed with medication for life?
That's an interesting question. So we don't completely understand how GVHD occurs, and if we can stop treatment or if it can just phase out on its own. Do we see rare patients that do have that? Yes. Where they can stay off therapy? Yes. But most patients have at a low level some form of mild symptoms persist even if they have been weaned off. Even if that has been a possibility and patients have been weaned off therapy, I still highly recommend routine continued follow-up to monitor for early signs or symptoms of recurrence or coming back of the graft-versus-host disease in all organs, including the eyes, for example. So once a patient has been diagnosed with graft-versus-host disease, even if it doesn't involve the eyes, I always refer a patient to the ophthalmologist to look for early signs or symptoms of GVHD of the eyes and have them continue to follow up yearly at a minimum to have that checked. So because what you want to do is be in a position to prevent any other and detect early any other manifestations of GVHD that might affect your quality of life. So it's the immune system is very unpredictable, and so I don't know that the burnout is something that I guess I don't know how to answer that question. I don't know if I believe in burnout necessarily. It's not, but I think that you have to always be vigilant for recurrence.
Okay. Thank you. Any recommendations for chronic management of acid reflux with chronic GI GVHD? Any guidance in, for example, the long-term use of, and I may mispronounce this, OMEPRAZ? Yes, thank you.
So we have not, to the best of my knowledge, studied long-term use of proton pump inhibitors, omeprazole or pantoprazole, in patients with GI GVHD. There are studies with this class of medications just in general with malignancy, but specifically for GI GVHD, I'm not aware of. But it is one of the most effective medications, if not the most effective medication for managing acid reflux. And so if symptoms require it, then your hands are tied. The patient should be on it, should take it. But in that sense, I would defer again, to that multidisciplinary care team and talking to your GI specialist to see if there are other causes of the persistence of that heartburn, such as with infections, for example, making sure that there's no H. pylori co-infection or something like that. So, so making sure you're crossing out all the other potential causes and leaving you with the need to just stay on that long term. So regular and routine follow-up, if symptoms are persisting, is necessary. And if that requires repeat imaging or repeat endoscopy, then I do think it's worth it because it's obviously affecting quality of life.
Okay. I am almost 4 years from my allogenic transplant and have minor/moderate chronic GVHD, dry eye, dry mouth, mouth sores, and esophagus stricture. I'm taking Tracro for these GVHD symptoms. Is ruxolitinib or belumosudil a better approach?
So hard to answer. So things that we have to keep in mind for, hard to answer because I don't know your specific case and your details, but things we have to keep in mind for ruxolitinib and belumosudil are that they are not without their own side effects. So your provider is most likely weighing the risks and benefits of those side effects versus how well you're tolerating the tacrolimus. If you're having very mild symptoms, and then perhaps not. Perhaps they could give you better control potentially. So something to discuss with your provider. So possibly. I don't know, but I don't know if ruxolitinib is the right thing for you necessarily, depending on your counts, because ruxolitinib, for example, can decrease your blood counts. So if that's a concern, then that might not be an option. Belumosudil does not have that as a side effect, so that could potentially be an option. But it depends again on the severity and the balance of the risk benefits of each of these drugs, but it's certainly a consideration.
Okay, thank you. This will have to be our last question as we're running out of time. Unlike liver GVHD, is it possible or common for GI tract GVHD to present itself with a distended stomach absent the more common symptoms that accompany GI tract GVHD of nausea, diarrhea, lack of appetite, weight loss, etc.?
So a distended abdomen or a bloated abdomen in this case, I want to make sure that I'm understanding it properly, because you can have abdominal distension or enlargement of your belly or swelling of your belly from gas, or you could have it from fluid accumulation. And for the latter, if it is fluid accumulation, as I had mentioned, abdominal swelling or ascites fluid accumulating there is a sign or symptom of liver dysfunction. So that possibly could be related to the liver. If it is due to the GI tract causing a lot of bloating, etc., that again could be a different GI process entirely. Could it potentially be GVHD? Yes. But it would be worthy of a thorough physical examination, potentially even abdominal imaging, which could be CT or MRI, to evaluate, or potentially ultrasound as well, to evaluate whether it's, to evaluate what the cause actually is. So hard to speak to, but could actually be your liver rather than your GI tract. But yeah, I would follow up with your provider about that specifically.
Okay, we have time actually for one more question, because you were very efficient in answering that, so thank you. Can GVHD affect bladder, causing pain, frequency, urgency?
So I can never say never with GVHD, because we have classically always said that GVHD can affect any organ system in the body. So I have personally not seen bladder involvement, but what can happen with GVHD is that the treatment that we're giving you with suppressing the immune system can put you at higher risk of infections that can cause those symptoms. So when you say that to me, I'm thinking automatically, is this BK virus, for example? So BK virus is a virus that will reactivate in patients that are immunocompromised and can cause those exact symptoms. Or it could be the symptoms that you're having could be a side effect of a medication. So unclear. I have personally not seen bladder graft-versus-host disease. Vulvar GVHD is very common, or vaginal GVHD is very common, but bladder specifically I cannot speak to.
Okay, well, thank you so much, Dr. Choe, for sharing your time and expertise. On behalf of BMT Infonet and our partners, I would like to thank Dr. Choe for a very helpful presentation, and thank you, the audience, for your excellent questions. Please contact BMT Infonet if we can help you in any way, and enjoy the rest of your symposium.